Welcome to the Cataraqui Woods Dental Implant Institute, a nonprofit organization dedicated to furthering both education and research in the field of oral implantology. My name is Dr. Waji Khan. I'm a dental surgeon and also the course director for a series of online lectures provided as a service to the profession of dentistry to deliver a literature and knowledge-based approach to dental implant education for practitioners interested in learning more about how to implement the discipline of oral implantology into their clinical practice. This online course should be merged with a suitable clinical course and long-term mentorship study club program so that the learner can maximize their benefit from the didactic online program. So we have an addendum to our dental implant course, and this addendum lecture is about smoking cessation. Now, I've included this despite the studies out there from Germany, which basically indicate that the success rate of dental implants in smokers versus non-smokers, that there is no real statistical difference. We do know that smoking cessation is beneficial for our patients for many other reasons. Smoking cessation helps prevent periodontal disease. Smoking cessation helps prevent incidences of oral cancers. Smoking cessation helps prevent the incidence of bladder cancer, skin cancers, lung cancers, all types of other problems that can sort of exist. Emphysema and other types of obstructive pulmonary diseases and stuff. So what we need to do is try to, as oral healthcare professionals, it sort of behooves us to promote smoking cessation in our practice. Nonetheless, however, this presents itself as a tremendous barrier for us. And one of the reasons I've included this lecture is perhaps we need to study some of the models out there that have been put forward to promote smoking cessation in patients and try to adopt these or implement these into our clinical practices. So we asked the question, why is it so hard to quit? Well, I mean, plain and simple, if it was the case that somebody was smoking and it made them feel bad, they wouldn't do it. People smoke because it makes them feel good, right? This is the basic principle around anything. We learned about this in first year biology. We had a professor at the University of Toronto in biology, I think it was Bio 150, and more or less what he used to talk about was something called a dung fly. And we said, what's the dung fly? And he said, well, the dung fly is basically a fly that eats feces. And we were all sitting there wondering, okay, well, why would a fly want to eat feces? Well, basically, in our own opinions, what is sweet? What's the definition of sweet? Well, basically, we say, oh, sweet is something that's sweet. But when you actually think about it, sweet is basically a substance like glucose or sugar that basically hits your tongue. It hits a receptor. That receptor triggers a neuron, which sends a signal to the brain, and the brain says, wow, this is something that's good. And it's similar for the dung fly. Basically, when the dung fly approaches dung, it goes and it eats the dung, and more or less in a similar sort of manner, it has a signal sent to its brain that this is something which is good. So it's hard to quit for one reason. It's because smoking makes people feel good. If it was the case that we could find some manner in getting people to smoke, just like with alcoholism, we have things like disulfiram and other substances that can basically make people not have a positive experience from consuming that substance. If it was a case we had something like this, it may be easier to implement something like that. But still, nonetheless, even in studies with patients who take disulfiram, we do know that these people can sometimes continue to have issues. So this is going to be just one segment. So when we say why is it so hard to quit, we have to look at the multidisciplinary model of evaluation of why people smoke. So the first thing we look at is what they call the physiological need, the body's need for nicotine. So people become addicted to this, and they have a physiological need to have the nicotine. So one's going to intuitively say, well, why don't we just substitute that nicotine for the patient with something like Nicorette gum or the nicotine patch? And even despite the use of these things, we can't get people to quit. So there must be more to this model. So we tend to take a look at the psychological aspect, the physical habit, the routine, the cycle. Speaking from my own experience, I have my own habits and routines and cycles. For heck, we're dentists. I mean, we hate paradigm shifts. We like doing things in a routine, circular sort of way. So in my sort of habit, I have my morning routine, my breakfast routine, my practice routine. Have you ever noticed that whenever that routine is broken for some reason, you just don't feel right? So if you woke up late and you didn't have a chance to shave, and for the rest of the day you just don't quite feel right, or you ran out of a certain material in the office and you were forced to use a different material, and you even though you go backwards and take a look at the restoration and it looks perfect, but all of a sudden you're saying to yourself, yeah, I'm not quite sure if this is what I'd routinely do. And this is basically going back to that psychological habit, routine, or cycle. So for a lot of these people, the problem is they're just getting in the habit of lighting something up, putting something in their mouth, holding something in their finger. So some patients we've actually addressed, we've given them Nicorette gum, and from a psychological perspective, we've tried to reprogram them into having sort of different habits. So something for us, which is cheap to promote, say, is just, okay, every time you think about smoking, go and brush your teeth or go and floss. Some patients even walk around holding a straw on their finger to sort of mimic the action of holding a cigarette. Some patients will go and chew gum every time they want to sort of complete that cycle or habit or that routine of having lit up a cigarette. So the next thing we look at, the third thing, is the sociological aspect of smoking, the associations, the bars, the sports, the drinking, the culture, the friends. And you are all of a sudden going to say bye to all your friends. So when I was in the Navy, basically on the port side, so port, the four-letter word means left, so left side breezeway of the ship, that's where all the smokers used to smoke. So all the smokers would be in port side breezeway and everyone else would be somewhere else. So all of a sudden, you're kind of identified as that individual who hangs out in Portside Breezeway. And now all of a sudden, going to the bars and watching sports and having a few smokes, or going out for a few drinks or dinner, or some of the other cultural things that are associated with smoking. All of a sudden, you're going to ask someone to give this away. You've given them a Nicorette patch. You've asked them to have different habits and cycles, but all of a sudden it's that sociological association, that need for belonging, that from Maslow's hierarchy, that we just don't quite give these folks. So you need to address these points in any sort of a quit strategy, because if you don't, basically it's a lot easier for someone to relapse and go back into the habit of smoking and be able to have these other higher level needs addressed, as opposed to just saying, okay, I'm going to quit and give all this up and adopt something else new. Or as I say to some patients, sometimes it's just a matter of going out there and asking your friends or asking those associations and stuff to help you get to the other side, or get a sponsor or get a friend who can help you quit along with you. The last thing is, from a philosophical perspective, smoking is like a blankie. So philosophically, it's like that identity. Someone, not to label people based off what they do, but we always tend to say smokers, right? Smokers. I mean, calling someone a smoker it's kind of rude. You don't label people based off their disease. I had a mentor of mine in internal medicine, Dr. Hudson. He passed away about a year ago. He was a phenomenal man. And one time, some of the medical students at the hospital used the term, these diabetics. And he said, why are you calling them diabetics? Diabetes is a disease. Diabetes is not a label, right? So we call people smokers. Smoking is a habit. Smoking is not a label. It's rude of us to call people smokers. So I like to say in my practice, people that smoke. So if you catch me saying smokers, tell me I owe you a quarter. And similarly with other things like calling people diabetics, it's people that suffer from diabetes have these sorts of outcomes. So let's move on to our next slide. So when we take these 4 points, more or less what we want to do is we want to say we need to formulate a strategy for the patient to quit. So you take all of these 4 factors to try to create a strategy for the patient. And you need to have a checkbox in each box to address each factor. And what I always ask my patients is, what is your primary strategy to quit? And then what is your secondary strategy? And then finally, what is the net benefit to you? And then the last thing we have to ask yourself in reevaluation is, why again haven't you quit? Sorry, I don't understand. So we take a look at strategy, and we basically say to the patient, number 1, do you have an urgent need to quit? Now, someone who's diagnosed with lung cancer, I mean, obviously there's going to be an urgency to not smoke, but somebody who just has, say, nicotinic stomatitis on their palate, and you identify this, you show them pictures, they may not be as urgent in need. So you need to identify this sense of urgency for the patient to quit. Number 2, does the patient have all of the information they require, or do they have a tick mark in all of the boxes that we have identified? Number 3, does the patient understand why they need to quit? So remember, you're battling against something which makes the patient feel good. If you need to give them basically enough ammunition to say, okay, these are the reasons why you need to quit, and we're going to help you. Number 4, does the patient have the ability to quit? I talked about the philosophical aspect and the associations aspect, and sometimes people have friends, and it's a matter of getting a sponsor to sort of help you, or a friend or family. I remember when I was a kid, my dad one time had a cigarette, a buddy of him would give it to him. My dad would never smoked, but he just had one. And as young children, we looked at our father, we said, Dad, don't smoke, we love you, we love you. But I mean, it's the same thing with myself as an adult. A friend of mine comes to me with a cigar and says, hey, what do you think about this? And I've got children as well. My kids say to me, Daddy, Mommy said don't smoke, it's bad. So I mean, these are things that we need to innately ask ourselves. Does the person have the ability to not do this? And if they don't, what sort of outside intervention can we provide to them? Number 5, why does the patient not want to quit? So the first point we talked about is that it makes the patient feel good, right? Or some of the associations or the philosophies or the identities or the physiological aspects. So you need to basically address this in your strategy. So in the next slide, we talk about our agenda for this program today. So basically what we want to do, basically I think I've summarized the major points that I wanted to make in this presentation with respect to getting people to quit smoking. But we're going to talk about smoking cessation, and just as a full presentation, this is going to be geared towards not just necessarily dental practitioners who will be watching this video, but for patients who may be accessing this online as well. So why is tobacco bad? Number 2, we're going to talk about the oral effects of tobacco. Number 3, we're going to talk about some of the tissue changes that can take place, and we're just talking about oral tissue changes. Number 4, we're going to talk about cancer. Number 5, we're going to talk about gum and tooth diseases. And lastly, what you can do and why it's important. So as you can see in this photograph here, this is a patient who has, from a black and white perspective, an ideal dentition. The dentition looks nice color, nice aesthetics, nice shape, nice form. It functions well. There's no temporomandibular joint disorder. I mean, this is what we're aiming to achieve. And so when we take a look at a color photograph of this, this is what this sort of looks like. And when we peel the gums away and everything, and look at it from the side, you can see that the tooth has enamel, it has dentin, it has a root, it has a nerve. There's a periodontal ligament that sort of helps keep that tooth inside the body, and inside the body we mean inside the bone. And there's also a mucosal or a gum, a gingival element that sort of helps provide support for this apparatus as well. This is all in health. So why is tobacco use important to implant dentistry? So there's many detrimental effects from smoking with respect to the teeth, the gums, the soft tissues of the mouth, and a significant difference to the success of various dental treatments. We talked about success rates of implants, but we didn't talk about success rates of grafting. So smoking does reduce the amount of blood that goes to a site, and basically when you're doing surgery on a patient, you need blood to go to that area. If blood doesn't go to that area, the area doesn't heal. If the area doesn't heal, you guessed it, the area gets infected, and the area can necrose, and the area can cause problems. We also know that periodontal diseases or smoking basically causes a lot of buildup on the tooth surfaces, and a lot of the soot or tar and calculus and stuff that's building up around these teeth basically causes an inflammatory reaction that recruits cells that destroys the bone and the periodontal ligament around the teeth, basically making people worse off. So tobacco's effects, and the earliest sort of effect is nicotinic stomatitis, and basically this results from the irritation and heat produced from the chemicals in tobacco smoke. And it can be reversed if smoking is discontinued, and these are seen as these basically red lesions in the palate from the hot cigarette smoke. We also can see things like leukoplakia and erythroplakia, and basically these are leukoplakia are innocuous white spots, and erythroplakia are innocuous red spots anywhere in the mouth. We'll talk a little bit more about this. Then we see something like a late squamous cell carcinoma on the front of the tongue. And basically you can see here there is some surrounding leukoplakia, there's some erythroplakia, there's some invasion, there's some ulceration inside this lesion. There's also another picture of a late stage squamous cell carcinoma of the lower lip. Once again, you can see redness, you can see breakdown of the tissue, you can see ulceration. So smoking is the primary culprit in oral dysplasia. Why? Most patients with dysplasia smoke, and many dysplasias regress when a smoking habit stops. So why can't we get these people to stop? We also know that alcohol has a synergistic effect with tobacco in terms of causing oral dysplasia, that there's a 2.4 times risk of dysplasia with just smoking alone, and that this risk is magnified to 15.5 times with smoking and daily alcohol consumption. So if you see something like leukoplakia or erythroplakia, the only way to know what it is to have a biopsy by a healthcare professional to examine the tissue under the microscope. And the only way to know for sure if you have red or white spots in your mouth is to have regular exams of your mouth done by a trained dental professional. So here's a picture of just some leukoplakia of the gingiva. Here's a picture of an early squamous cell carcinoma of the side of the tongue. And in terms of oral cancer, we're going to talk about oral cancer representing about 2 to 4% of all the cancers that exist out there. And usually this is seen in patients over the age of 40. and known risk factors of smoking, alcohol, human papillomavirus, and it can occur on the lip or the mouth, and usually survival depends upon the stage of diagnosis and treatment. So if this is picked up early on in stage 1 and 2, the 5-year survival rates are around 70 to 90%. And if they're picked up in stage 3 and 4, the 5-year survival rates drop to about 30 to 40%. And so in this photograph here, you can see an early squamous cell carcinoma of the lower lip. In this photograph here, you can see an early squamous cell carcinoma of the side of the tongue. In this photograph here, you can see an early squamous cell carcinoma of the mucosa. And basically, we've been showing all these pictures because not everything necessarily is going to be squamous cell carcinoma. So the one on the left is the picture of the squamous cell carcinoma on the side of the tongue. Above, on the right, you can see trauma to the side of the tongue, which looks very familiar, or on the bottom, chronic cheek biting. And for patients who have these things, basically, trauma to the side, if you address the thing that caused the trauma and you let the area heal, this will heal in 2 weeks' time, whereas the squamous cell carcinoma will not heal. And also, if you biopsy these two things, upon biopsy, upon histology and microscopically looking at these tissues under magnification, one will notice a difference in how these cells present as well. So another photograph of a late-stage squamous cell carcinoma of the floor of the mouth in an edentulous patient. And on the right, a late squamous cell carcinoma of the roof of the mouth, and this is for a partially edentulous patient. So in the partially edentulous patient, many times people require surgery. So something like this needs to be done in order to address the cancer. So usually with cancer, there's 3 cardinal treatments. Usually it's surgery, chemotherapy, and or radiation. So in the old days, we didn't do chemotherapy for squamous cell carcinoma. Recently, that has been adopted as a treatment regimen. But some people can get these significantly debilitating surgeries, which have a significant amount of morbidity associated with them. So this patient here had a maxillectomy to basically create a surgical defect which exposes the sinus to the oral cavity. So every time you have a drink, it goes down your nose. And so you need to put something in like a palatal obturator. In this picture here, this patient has a removable obturator in place to sort of help address this palatal defect. Nonetheless, I mean, this is basically there to sort of help, but by no means is this a substitute for what this patient has had to endure. So in terms of the effects on teeth and gums, there's a number of things that can take place from smoking. The biggest thing would be tobacco staining. Smoking causes calculus accumulation on the teeth, and it also causes tooth surfaces, which are more likely to cause the accumulation of bacterial plaque, which can lead to both more tooth decay or gum disease. In terms of other things that can happen with smoking, periodontal diseases have been related to patients who smoke. Many studies have shown that smokers are at a higher rate or risk of periodontitis than non-smokers, and the risk ranges from about 2 to 5 times as compared to non-smokers. If we take a look at this photograph right here, you can see what sort of periodontal disease kind of looks like. So we all know the picture on the right is healthy teeth, healthy gums, and the picture on the left is diseased teeth, diseased gums. You're seeing a periodontal pocket, you're seeing inflammation, you're seeing destruction of the periodontal ligament, destruction of the bone. In this picture here, you can see what healthy bone levels look like and what the bone levels look like in patients who have severe bone loss due to periodontal disease. Once again, here's another picture clinically showing severe bone loss around a molar tooth due to periodontal disease. So gum disease, why? So basically, smoking changes the composition of the bacteria in dental plaque, and smoking also causes an increased level of inflammatory mediators leading to greater tissue inflammation. Smoking also affects the body's immune response to the presence of bacteria causing periodontal disease. Smoking causes vasoconstriction of peripheral blood vessels. Good tissue blood supply is necessary for an adequate immune response against periodontal bacteria. So here's a photograph of a patient who it was a smoker. So the patient of mine who we treated, we tried to get this patient to quit smoking, and we're not going to show you this exact patient, but you can see we've done a number of amalgam restorations. We can change these in the future to white-colored restorations. We can smooth these teeth. We can get these stains off these teeth for the patient. We can whiten these teeth. We can do things like veneers, crowns, just simple composite resins. We can get this guy looking good. Here's a picture of a patient who did quit smoking. That's not the same patient, but this patient came in. Basically, we said, okay, now that you quit smoking, you've got your gums healthy. Hey, what can we do for you? So we basically just through simple conservative composite resin bonding, we were able to do this for this patient. So in terms of messages that are sent out there. This is Christy Turlington, who used to be a supermodel back in the 1990s. And basically, this is an interesting post that I found, which states that in 14 years of modeling, this is my favorite shot of myself. And this is basically a clear chest x-ray with no signs of any issues. And basically, it states right here, Christy Turlington considers quitting smoking her biggest success, and one of her biggest regrets is that she never started. Is that she ever started. So this is from the Center of Disease Control and Prevention. So a summary of what we talked about in today's presentation is more or less things that smoking causes from an oral health perspective. So we talk about nicotinic stomatitis, we talk about red and white lesions, we talk about oral dysplasia, we talked about oral cancer, and then we talked about tooth staining and decay. And lastly, we talked about things like gum disease or periodontitis. Oral healthcare professionals have an ethical responsibility to inform their patients about the risks that are associated with tobacco use and encourage their patients in their smoking cessation efforts. So don't be surprised if your oral healthcare professional talks to you about smoking cessation the next time you're into the dental office. Also remember that your mouth is a part of your body. Many times people forget about that. What is the best oral healthcare routine? The best oral healthcare routine is the one that is used. As Dr. Phil McGraw, Dr. Phil, as everyone knows, would say, you have to start being honest with yourself first before you can achieve anything meaningful. So with that being said, let's try to quit the habit. I've attached a few references here that we used in the production of this presentation. And on behalf of the entire dental treatment team at the Cataraqui Dental Implant Institute, I want to thank you for listening in on this presentation.